So, macam mana nak buat newborn screening? I think you all need to know this newborn screening. You all 5th year already.
From observation and the color of the baby, pink or cyanide, and jaundice, any spontaneous movements, crying, any single features, and for the head,
What else on the scalp that you want to do? You need to look for? Can? Sama? Alright, when you examine for the scalp, look for the scalp swelling lah. Okay, so what scalp swelling that you know of? Shignon is not scalp swelling. Shignon is just the cup, vacuum cup marking. That's all. But there's no swelling involved. Alright, the one that you saw just now is just shignon. There is minimal a bit of edema. That's it. There's no swelling lah per se. Okay. So the scalp swelling per se is your kephalohematoma. What else? Caput succedaneum, and then subgaleal hemorrhage lah. So what are the difference between those three?
Caput is beneath the skin.
Okay, skin edema. Okay. Caput basically is just a skin edema lah. Alright, why it got edema? Because that part of the skin basically trapped to certain direction, so it become edematous over time lah. When contoh the head already molding for so long, that molded part is become caput lah over time. Alright, so what else about caput features?
It's localized, contained, cannot spread.
Okay, usually they don't spread, but the edema basically can happen anywhere. Can happen on anywhere got skin on the scalp, even the face, the edema can still happen lah. So the caput basically can be any shape, can be any direction, depends on where the skin got trapped, and then it become edematous lah. Because when the skin got trapped, your lymphatic drainage and all that is not that good. So that basically accumulation of fluids lah over time. Okay, why that's what happen lah when patient have molding engaged for quite some time under there, for example. Alright, so can caput have bleeding? Yeah, there can be some bleeding inside the skin layers lah, and the epidermis or epidermis layer, whatever it is lah, I also don't remember lah. So but the bleeding usually not so bad lah. Okay, alright, so and then caput also they're not tender per se lah. Alright, they can be tender lah if got bleeding inside lah. Okay, alright, then what about kephalohematoma? What are the features of kephalohematoma? Tender, non-tender? No, kephalohematoma non-tender. Alright, because it's a periosteal bleeding. So your basically the upper part of your bone. Okay, bone basically don't have nerve per se lah on that surface. Okay, so that's why it's non-tender. Does it cross sutures or not? It doesn't cross sutures lah, because bone got sutures lah, suture line, so it won't cross over the sutures. Okay, so if happen at your parietal bone, it just stay at the parietal area. If it happen at your punya occipital region, then can most of the time occipital region lah, but most of the location is occipitoparietal region lah. Alright, okay. Does it well demarcated or diffuse swelling? No, it's a well-defined lesion. Usually it's a circular kind of lesion lah. Alright, it can be single, can be bilateral. Okay, so those are the features. Then subgaleal hemorrhage, tender, non-tender? Tender. Why are they tender? What are the other names of subgaleal hemorrhage? Yeah, so aponeurotic. Say got neuron there. Neuron is your nerve lah. So you got nerve supply, got sensation. Alright, so that's why they are painful. Okay, when you touch them, and then they cry, baby cry, you know lah, it's painful. That's how we know lah, that thing is painful or not. Okay, and then does it diffuse swelling or well-defined swelling? It's a diffuse swelling lah, because aponeuron layer don't have, it cross everywhere lah, even it cross your sutures. So it can be diffuse swelling. If the hemorrhage is very bad, basically the whole scalp can be swollen lah. So which one can cause hypovolemic shock? Subgaleal or cephalhematoma? Subgaleal lah, because there is nothing stopping them to go anywhere. Okay. So subgaleal hemorrhage can cause hypovolemic shock. Okay, if you see the swelling is very bad, tender, and then they're also very boggy. For cephalhematoma, they are soft, but they're not really boggy lah. Okay, but both can predispose patient to jaundice lah, including your caput lah if got bleeding. So basically those are the features we expect you to answer lah, in terms of the tenderness, location, does it cross sutures or not, which one can cause severe swelling and hemorrhage. Alright, okay, that's what you examine for the scalp lah. Then you also examine for the fontanelle. So fontanelle, we see lah whether fontanelle is very narrow or fontanelle is very depressed. Okay, narrow sometimes because of the head molding lah. The head molding, the sutures basically mold on top of each other, the anterior fontanelle become very small. But when the head start to pop back to the right original location, then your anterior fontanelle should be bigger in size lah over time. Okay, and then
that's not really pathological.
No. The molding happen because it's delivery process. Okay, and then there is also third fontanelle, posterior fontanelle that you may feel in some patient lah, but most of the time it's either anterior fontanelle or posterior fontanelle. Okay, and then next, where do you examine? After the head, goes where? See the eyes lah. See the eyes, see got some dysmorphic features of the eyes, hypotelorism, hypertelorism, up slanting, down slanting. Okay, then you see the looks for the cornea and the pupils, whether got some cataract or not. Okay, some may see the obvious cataract lah, but the best thing is to do red reflex lah. Okay, but some red reflex also sometimes can be a bit difficult lah. Baby most of the time crying, bit susah to open lah. Okay, but sometimes we expect you to do also lah. Okay, red reflexes, see for the any absence of red reflex. If absence of red reflex, what does it mean? Yes, retinoblastoma. Okay, alright, then the next thing you examine after the eyes, go down with the mouth. Before the mouth, the nose first loh. Okay, sometimes you may hear noisy breathing. Okay, sometimes the nose got choanal atresia. Later on they try to insert the thing. The nose choanal atresia, sometimes they suspect because patient, when they stop crying, they become blue. So when they cry, they're not blue lah, because if both nose is obstructed, nose not breathing, baby is obligate nasal breather, mean they're breathing totally through the nose. When they open the mouth, they cry, baru the air goes in, then the oxygen go back to normal lah. That's how you suspect choanal atresia lah, per se. Right, then the mouth, what do you examine? Cyanosis. Okay, what else inside the mouth? Your cleft lid and cleft palate lah. So cleft lid is obvious, you can see. The difficult part is to detect the cleft palate. If cleft lid and cleft palate come together, then okay lah. But sometimes there can be isolated cleft soft palate only. Cleft soft palate means the posterior part. This one you need to examine and feel with your tongue, or basically obvious direct observation lah. Okay, you see for yourself. Okay, alright. Then the neck nak check for what? Sometimes don't forget the chin. The chin can be very small or micronetia. It's quite common. We say not saying it's common, but you can see lah from time to time. Micronetia baby, they can have some respiratory problem lah. Alright, the neck, what you want to look for? Any neck swelling lah. So common neck swelling apa? Cystic hygroma is the most common thing lah. Next. Can be your branchial cyst, can be your tigroclosis cyst lah. Alright. But most of the time it's always cystic hygroma lah. Alright. Okay, next habis the neck, you go where? Chest. So chest check for what? Any chest deformities lah. Sometimes they can have pectus excavatum, pectus carinatum lah. And don't forget to count respiratory rate lah. See got any recession or not lah. Then you auscultate, listen for the murmurs. Sometimes day one also got murmurs. Those yang very cyanotic disease or very severe pulmonary stenosis, severe valve regurg, you can hear the murmur from day one itself. Okay, may auscultate the lung, but most of the lung finding is normal lah. But if got congenital pneumothorax, you can hear reduced breath sound left side. If got congenital diaphragmatic hernia, you may hear bowel sound in the thoracic cavity lah. Doesn't matter left or right. Okay. Alright, then abdomen, what you want to examine? Umbilicus got how many artery, how many veins? Two arteries, one vein. So look for it. It should be Mickey Mouse new location, the ears and the mouth. And then some of the problem may have single artery, single umbilical vein lah. Those can be associated with some kidney problem. So you may want to order kidney ultrasound lah, ultrasound KUB. Alright, then look for abdomen. Basically, see scaphoid or not lah. If scaphoid abdomen, what does it indicate? Scaphoid abdomen, can you hear bowel sound in the thoracic cavity? What does it indicate? What does it tell you? CDH lah, congenital diaphragmatic hernia. Okay, you can also palpate for the mass lah, either hepatomegaly or not, or sometimes very well defined mass lah. Sometimes it can be so many things lah, some inside some lesion, tumor, whatever lah inside the stomach. It can be some cyst also lah. Alright. Okay, then abdomen. After that, you go down a bit, which is your genitalia lah. So genitalia, you look, examine for is it female or male genitalia lah. Look for it whether you can easily tell this one female or. Sometimes they can have ambiguous genitalia. If got if female, you see for got opening or not properly, got urethra and then vagina. Then for the boys, looks for hypospadias and then two testes, no? Okay. Some may have undescended testes, especially the prematures. Alright. So at the same level and the inguinal region, so you examine for femoral pulses lah. So femoral pulses weak or difficult to feel. Tell you what? Difficult to feel femoral pulses indicate what? Tahu examine tak? Okay lah, tapi need to know lah what are you examining for? I dah dengar jawapan tapi tak dengar sangat. Apa dia? Coarctation lah. Okay. Alright. Then at the hip also you examine for what? Look for DDH lah. Do the ortolani and Barlow. Okay. Then you go down a bit below the genitalia. Ernest lah, this is basically the most important thing when you do why you do newborn screening. You don't want to miss this. Okay, you miss the imperforate Ernest, the result can be disastrous lah. Because if you see patient, okay lah, you cakap the patient have Ernest, you start feeding. You bagi feed after 24 hours still tak ada BO, then the stomach gonna burst lah. It can become perforate intestine. Okay, then the kaki look lah for any obvious extra fingers, obvious deformity, and then any CTEV lah. Okay, after that you go turn patient to the back, examine for the spine. Okay, spine tengok, look for what? Okay, all those sacral dimple, tuft of hair, those are basically spina bifida occulta lah. Of course, you look for spina bifida also. On top of it, spina bifida can happen at any level lah, cervical, thoracic or lumbar region lah. Kalau happen spina bifida basically benjol at the head, is encephalocele lah. Alright, last one you do your moro lah. Okay, moro reflex. Okay, then of course at the mouth also, when you checking for the cleft lip, cleft palate, always assess the sucking. Alright, think that cover most of it lah. Newborn screening, probably I miss here and there lah, but roughly that covers most of it. Okay, dah, any question?
You check the spine, do we also check the alignment?
No, it's a bit difficult lah to tell baby here and there. How do you know patient got scoliosis or not lah? Sometimes the obvious one, yes lah, but no lah, not really. Okay.
You have to do measurement,
Weight and height and COH is already measured from the moment baby is born lah. So you just basically have to trace the measurement lah. Okay, what do you do with the measurement? Growth chart lah. So what to determine patient appropriate for gestational age, or large for gestational age, or small for gestational age. Okay, if you talk about it for prem, you can use the growth chart lah to basically call it whether patient SGA, LGA or AGA lah. For term, sometimes we only use the definition based on weight. Okay, so term AGA 37 weeker to 40 weeker 2.5 to 4 kilos, just based on the weight. Less than 2.5 is SGA, more than 4 kilo LGA. Okay, for prem use the growth chart. Okay, alright, any more question? No more. Tak apa, tak ingat, go find this video on YouTube.